So I welcome all the participants for day 5, and you had a very good session with Dr. Anup Ghosh about the molecular diagnostics and the MALDI-TOF for fungal isolate identification. And now we are entering into antifungal susceptibility testing. So antifungal susceptibility testing has many challenges, and particularly for resource limited settings, it is always like we want to do, but we feel a little hesitant to start and perform. Because there are these challenges we would understand, and I feel that everyone will be encouraged to do the antifungal susceptibility testing once we know when we have to do. Is it mandatory to do for all the isolates, or only selective isolates we have to do, so that we have a limited burden of doing antifungal susceptibility testing and we do it very meticulously. So what is the need for AFST? So over the period of time, what we have observed is that the risk factors, the number of patients with risk factors for varying reasons, let it be immunosuppression, let it be long hospital stay, and more of the cancer patients, or patients on chemotherapy, more of the transplant patients. And now we have seen invasive fungal infections just walking in because of the COVID into the hospitals. So because there are increased risk factors, new risk factors, what we are seeing, so there has been a concomitant increase in the invasive fungal infections. Now, at the same time, what we are seeing is that the scientists are busy in propagating or in creating new antifungals. So the antifungal drugs, their range has also increased, and then there are newer antifungals which have come. So to see how good they are functioning and what is their in vivo performance compared to the in vitro test. So for all these challenges are there, and there is an increase in the antifungal armamentarium. Second thing, what has been seen is acquired resistance, which has emerged in the fungal species. So it again is a requirement for which we have to do antifungal susceptibility testing. At the same time, there are several patients who are on antifungal therapy, and also there is a kind of every patient is different when it comes to fungal infections. So in vitro susceptibility testing is very, very important to accurately manage each and every case. So there can be intrinsic resistance, there can be acquired resistance. So all these things actually help us in, if we perform good AFST, we can manage the cases. So AFST is often performed by clinical microbiology laboratories as a tool to aid in the selection of optimal antifungal agent. So reproducible techniques of antifungal susceptibility testing, they're very, very crucial. For example, every thing has to be taken care of. Technicality, inter-laboratory comparisons, agreement between the techniques, whether they are broad dilution methods, whether they are disk diffusion methods, and if there are any automated methods. And also there has to be uniformity in the reporting among the observers. And it should be able to predict the outcome. It is very important that it is again helpful in the prognosis and in the outcome. So there are many factors which actually influence the outcome of in vitro susceptibility testing, like what is the endpoint? Because if we do not know how to interpret the endpoint, we may go wrong. Inoculum size of the organism, how to prepare the inoculum of the organism, how to grow the organism, which organism I should take, on which day subculture I have to choose, how long I have to incubate for which organism, what is the temperature of incubation, and what is the ideal culture media I have to use for testing. So these are some of the challenges. Then minimizing the influence of variability of all these factors actually is what is known as the standardization. So every lab takes some time to standardize because these are the limiting factors. And at the same time, these are resource driven because antifungals are very costly. So there is a lot of money that goes into it. And at the same time, it requires dedicated technical staff. So standardization, once you have achieved, then things are very, very simple. So without standardization, if you are performing, the results may vary and they will be less than optimal. So to begin with, the antifungal drugs, there are ergosterol synthesis inhibitors which act on the cell wall. So they're acting on the synthesis of the ergosterol. Then there are cell wall synthesis again, which is a different enzyme, that is beta-D-glucan synthase, which inhibits the beta-D-glucan synthesis. Some antifungals like polyenes, they act on the cell membrane. They are also affecting the ergosterol, but through a different mechanism. And nucleic acid synthesis, some antifungal drugs are there. So we are going to cover the aspects of antifungal susceptibility testing, and then slowly we are going to look at the other aspects. So among the triazoles, we have got fluconazole, itra, vori, posaconazole, and asuvoconazole. And the allylamines, which are usually working through the squalene epoxidase enzyme inhibition. So that is naftifine and terbinafine. These are predominantly used in the dermatophytes. Cell membrane, we know in the COVID times, we have heard enough about the amphotericin B, and there are different forms, deoxycholate, liposomal, and lipid complex. Echinocandins, they are acting on the cell wall synthesis through 1,3-beta-D-glucan synthase, and there is caspofungin, mica, and anidulafungin. Nucleic acid synthesis inhibition actually is done by 5-fluocytosine. So these are some of the antifungals which are there. So to start with antifungal susceptibility testing, second challenge is, if we have known what are the antifungals that have to be tested, and if we have technicalities, we have resources, which guideline to be followed, CLSI or the UCAST. So both guidelines are available, and we can select based on our suitability and what are the interpretative guidelines, what is the difference, and are there breakpoints available, is there available MICs for reporting. So all these are challenges, and based on our suitability and the population to whom we are trying to address, so we can choose the standards and the guidelines. Preferably what we select is the CLSI guidelines. Now the relevance of AFST in clinical laboratory is understood when you know for which isolates we have to perform, how we have to perform. So primarily it is done for ease. For molds, testing is with less frequency, and it has, AFST is not reported like in bacteriology. For each and every fungal pathogen, AFST is not advised. Isolates from non-sterile body sites are not often treated, and so no AFST is required. And antifungal drug of choice for some pathogens is empiric, and that empirical actually is assumed by proper identification of pathogen, and there has been no demonstrable resistance. So you can continue with that same antifungal without doing any AFST. For fungal pathogens with no established interpretative criteria, where there is no breakpoint and no epidemiological cutoff also, so MIC that has been obtained will be of will have no clear interpretation. So in those cases also it will be futile if you are doing AFST. AFST is particularly of value in invasive fungal infections, and in those cases where we are seeing increase in the acquired drug resistance, or when the patient is unexpectedly failing the therapy. So in vitro AFST pattern would inform the clinician when making therapeutic choices or changes. These indications for routine AFST have been defined for some species of Candida only. So this has to be understood very clearly because the MIC interpretative breakpoints are available for few species only. So we have to update ourselves regularly with the guidelines given by various working groups. So there are antifungal reporting and working group. So one group is working on intrinsic resistance working group, and another is body site reporting group. So the intrinsic resistance, if we look at it, is defined as inherent or innate antimicrobial resistance, which is reflected in the wild type, where there has been no documented. Wild type is that that isolate where there has been no demonstrable resistance. So antimicrobial patterns have been seen. So this is the intrinsic resistance in the wild type. So that is not acquired in any way, it is present. So inherent or innate antimicrobial resistance, which is reflected in wild type antimicrobial patterns for all or almost all representatives of species. So that particular species or the representative, like in the taxonomy, we have read that Aspergillus niger species complex has been grouped together because of the pattern of resistance. So that becomes a species complex. So intrinsic resistance is so common that susceptibility testing in those cases will be unnecessary. So that is very, very important, which we have to keep in mind. So relevance of AFST in a clinical laboratory by the intrinsic resistance working group, what they have documented, yeast and azoles. So now we have in taxonomy new names. So we are trying to utilize the newer nomenclature more commonly, like Pichia putrescens for Candida krusei. It is intrinsically resistant to fluconazole, and Candida auris and fluconazole, there are reports of intrinsic resistance, but still the group is working and there is no conclusion as strongly as in case of Candida krusei. Yeast and echinocandins, Cryptococcus, Rhodotorula, and Trichosporon species, they are intrinsically resistant to echinocandins. So in these cases, again, testing for echinocandins will be futile. Mucorales and azoles, if you look at it, they are intrinsically resistant to fluconazole and voriconazole. Molds and echinocandins, for mucorales, intrinsic resistance is seen for echinocandins. And Lomentospora prolificans, this also in taxonomy, we have seen that Schistosporium earlier it used to be caused. For this also there is recommendation for doing the antifungal susceptibility testing for other antifungals, but echinocandins it is intrinsically resistant. There is insufficient evidence on intrinsic resistance of Fusarium to echinocandins. So this is the particular area which is open for work and research, so that there will be further documentation and further data that will come up to know the pattern of intrinsic resistance for the Fusarium. So there are several ongoing assessments by this intrinsic resistance working group on molds and Candida lusitaniae as with amphotericin B. So if these things are updated regularly in the CLSI documents, that is M27, M59 and M60, which we need to be following on a regular basis. Now there is body site reporting group. Now this group again gives very good recommendations. And it explains to us, like in bacteriology, we have a selective reporting. We have tested many antibiotics and we report some. We hold reporting some of the antibiotics. That is known as selective reporting. We don't do reporting of each and everything. Similarly, antifungals which are appropriate for the organism and body site, they are routinely tested and reported. Not all. Routinely, even if you have tested and reported, isolates specifically from blood cultures are given significance, and that to Candida species. Amphotericin B is reasonable to test and there is no restriction on reporting. So you can report amphotericin B if you have tested. You need not withhold it. 5-flucytosine, always report with a comment that it should not be used as monotherapy for Candida infections, and rarely it should be used in neonates. Echinocandins and Candida CNS isolates report susceptibility, and the group says that you add a comment that echinocandins show low CSF penetration, or if you feel, do not report. If there is no request by the clinician, you can withhold it. Echinocandins and Candida urine isolates. So echinocandins are generally not recommended for treating candiduria, and because there are some tissue sites where the penetration is poor for echinocandins, and it includes like ocular tissue and body fluids also. It has been seen that the penetration of echinocandins is poor. So in those cases, you either have to restrict reporting or else report only when there is a request. And azoles and CNS Candida, ocular Candida. So in those cases, azoles that have to be reported routinely include the fluconazole, voriconazole. You can suppress or withhold the reporting of Itra, Posa and isavuconazole, and you can report only when it is requested. Azoles and urine Candida, reasonable to report fluconazole, whereas you can suppress the reporting of all other azoles so that they're not misused and they can be reported only when requested. So relevance of AFST in clinical laboratory is very, very high. Rates of drug resistance are obtained from AFST data. So these help us in creating the institutional antibiograms. And when we are going at a higher level, like some surveillance, nationwide surveillance, when it is happening, it creates a global wide monitoring of the antifungal resistance with the fungal pathogens. So this further helps us in institutional antifungal stewardship. And at the same time, many countries or many regions of a country, when they are giving an epidemiological cutoff value, repeatedly doing AFST, not in patient care, but in surveillance, that helps us in generating a cutoff value. So AFST is also valuable in development of novel antifungal agents. So here I want to give importance of by naming the different documents, because These documents or guidelines are very important when you want to do the AFST. So CLSI documents are M27, A3, A4. Now there is a 4th edition of M27 where we are doing, it is a document for yeast broth dilution technique. Mold broth dilution is M38A2. M44A2 is yeast disc diffusion. These are supplements actually, or additions. M51 is, which is there recently, many people are following this, mold disc diffusion, and it specifies about the non-dermatophyte molds. Whereas for the broad dilution of the dermatophyte molds, it was already incorporated around 2008 itself with M38. And M60 is the performance standards for AFST yeast. And M59, they give you the epidemiological cutoff values for antifungal susceptibility testing. The most of the above, like 27, 38, 44, 51 are paid. You have to purchase those CLSI documents, whereas 60 is easily downloadable, or else we can see them online, as well as 59, where we can observe the epidemiological cutoff values which are updated regularly. The corresponding UCAST documents include the EDEF 7.3.1 for yeast and 9.3.1 for mold. So these are the reference documents for the UCAST. So reference methods for susceptibility testing. So reference methods include the broad dilution. So broad dilution, we begin with the yeast. So we have two guidelines, and that is CLSI and UCAST. So what are the fundamental difference? The glucose content, the media that is chosen is the RPMI. Now this RPMI is with glutathione, and without, it is without your bicarbonate, and it is with or without phenol red. So here the media is RPMI. In case of CLSI, the percentage of glucose is 0.2, whereas in UCAST it is 2%. The preparation of antifungal agent is stock solution preparation 10 times higher, the highest concentration, whereas in case of UCAST it is 200 times higher than the highest concentration. And organism, how you are going to prepare, subculture, how many times you have to do, at least twice has been recommended by CLSI, but there is no recommendation by UCAST. Micro dilution plate that we are using is U-shaped wells in case of CLSI, whereas tissue treated plates with flat bottom have to be used in UCAST. Inoculum size is again almost it is higher in the UCAST, and 0.5 to 10 to the power 3 to 2.5 to 10 to the power 3 cells in case of the CLSI. Reading method that we find in CLSI is visual, whereas spectrophotometric in UCAST. For Cryptococcus, there is a difference of incubation, 72 hours in CLSI and 48 hours in case of UCAST. Amphotericin B reading 100% decrease in growth, or the first optically clear well, is what is chosen as the MIC. But in case of UCAST, it is 90% decrease in growth, because it is facilitated because you are reading it through the spectrophotometry. But that much difference to visualize is very difficult. And again, the UCAST recommends against the use of low evaporation lids. So they don't recommend much of the lids. So we come to the broth microdilution for yeast using the CLSI standard M27, and we are following edition 4. So this is what is the method that we are following. So antifungal agent selection and preparation, test procedure, and QC requirements have been mentioned in this M27 document. It describes the methods for testing Candida and Cryptococcus species. But there are some exceptions. They don't describe much about the dimorphic yeast. We cannot incorporate the same principle to the dimorphic yeast, and also to lipophilic Malassezia species. A separate CLSI document M60, it details the most current performance standards for the antifungal susceptibility testing of yeast, and contains MIC breakpoints, interpretative categories, and MIC ranges for the QC organisms. Now, with this yeast M27 document, microdilution plates is 96 well, polystyrene, untreated, U-shaped wells. Media is RPMI 1640 with L-glutamine and phenol red as pH indicator without bicarbonate. And this has to be strictly buffered to pH 7 with MOPS, that is N-morpholino propane sulfonic acid. Now, why MOPS? Because it is zwitterionic compound in nature, which is biological buffer. So it does not interfere much with what the AFST is performed, and the pH is attained by adjusting with sodium hydroxide. While adjusting the pH, you try to avoid using acid to adjust the pH. You don't make it more alkaline and then try to make it acidic by adding the acid. That actually fails your entire testing process. So it's always better that you go slow, you perform it well, and you try to increase the pH. You try to increase it. You try to make it alkaline by adding sodium hydroxide rather than avoiding by adding acid and lowering it. So MOPS is usually required in 0.165 mole per liter, that is approximately 34.5 grams per liter. And the RPMI 1640 medium should have a glucose concentration of 0.2%. So for preparation of antifungal agent, now that the media is ready, you want to prepare the antifungal agent. So it should be, antifungals have to be obtained from specific in the powder form in generic nature, and you should check for the potency as well as the expiry date. So usually there are many companies like Sigma, High Media, and several others. So you have to select them based on the generic name. You should not use the you cannot go and get any of the pharmacy product, and you should use it for antifungal testing. So once you get the drug, you have to determine the amount of drug that is needed in the solution. So there are two forms, water soluble and water insoluble. So for water soluble, your solvent is water, whereas in case of water insoluble, preferred is the DMSO, what CLSI recommends. So you have to weigh and you have to adjust again the volume to what you have weighed. So there are two formulas. One is for the weight. First you weigh by, you know, the concentration, you know, the volume, how much you want to prepare, and you know the assay potency, which is mentioned usually with the drug. So once you know how much how much you are going to weigh, so definitely during the weighing time, what happens is that something extra always goes into the powder when you're weighing. So now you have to adjust the volume to what you have weighed. So for that, the second formula is volume equal to weight into assay potency upon concentration. So the powder should be weighed on a calibrated analytical balance. So you should take care that your analytical balance is calibrated. And the log square concentration range of antifungal drugs should be selected to encompass the QC range, which is described usually in the M60 document, and then extend high enough to identify any resistant isolate. So initially it should be falling within the range of the QC. And solvents other than water, DMSO is recommended for those antifungals which are water insoluble. So once you have chosen your powder, you have weighed them, you have to prepare the solution. So for this, before starting to weigh also, you have to know what concentration you have to achieve for your stock solution. So that is your concentration. So you start with, for water insoluble drugs, it is 1600. That is what is stock solution prepared. For water soluble, you are starting from 5120. So that is the stock solution that you're preparing. And echinocandins, it can be 5120, 1600. So water soluble drugs, Casper, Mica, fluconazole, there are two varieties available. It can be water soluble. It depends upon the manufacturer, whether it is DMSO solvent or water soluble. So you have to check that. And water insoluble drugs are amphotericin B, anidulafungin, grisofulvin, itra, keto, pusa, terbinafine, voriconazole. Here 100 times higher than the highest concentration has to be derived. Now, another very important step, once your antifungal stock solution has been prepared, your media is prepared, you have to prepare the inoculum. So this is very critical step for ease. The inoculum preparation is 0.5 to 2.5 into 10 to the power 3. So 24 to 72 hour old culture on SDA, twice subculture, inoculum suspended in sterile distilled water. And you have to adjust the optical density to 0.45 to 0.55 at 530 nanometer in spectrophotometer. So we will also show you the video how to adjust. So optical adjustment in spectrophotometer, first you take a cuvette, you add water, and you take the wavelength at 530 nanometer, then set it at 0. Then add the inoculum what you have prepared to the cuvette and take OD at 530 nanometer. If the optical density is less than what has been mentioned, so you have to add the prepared inoculum, and if it is more, add sterile water and adjust. So these are different charts how we can prepare for the scheme of preparing dilutions, which is also mentioned in the. So you have to reach a final concentration of 1:5 microgram per ml. After that, these steps are done in the test tubes. Once you have reached this step of final concentration of 1:5 microgram per ml, then you start taking the microtiter plate, U-shaped microtiter plate, and you start adding the drug as well as the inoculum. So this is for water soluble. So your plate is, microtiter plate is ready, And in this case, you have to also keep that you are going up to 10 and last 1 or 2 your columns are free. They are for the growth control and the media control. That is positive and the negative control. Similarly, you have a separate flow scheme of preparing dilutions for the water insoluble. For fluconazole, it is slightly different, and for other insoluble antifungals, it is slightly different. So it starts from the what concentration you are trying to start, or what is your intermediate concentration, stock solution from where you are beginning and where you want to reach. So final concentration you are achieving in the tubes is 1:50. From there, you are starting to inoculate it in the microwriter plates. So this again we will show you. So broth microdilution test for yeast using CLSI method plating scheme is what has been depicted in this way. So up to 10. So usually you in your plate, you are trying to decide whether you want to perform multiple drugs on one plate with single isolate, or you want to perform multiple isolates with one drug. So what we tend to follow here is we perform multiple Candida species A, B, C, D, E, F, G. These will be different Candida species, out of which 1 or 2 A and B we keep usually as controls. And then we have one plate dedicated for fluconazole, or we have one plate dedicated for voriconazole. So there is one plate which is caspofungin, like that. So one whole plate is dedicated for one drug, antifungal. So that actually makes the things little less confusing, and the person can do it very dedicatedly. So in this, we have got the growth control, which is basal medium without antifungal to assess the viability of the test organism. So this is how you look at the growth control. Purity control, actually, we usually perform on the plate. So sample of each inoculum is streaked on a suitable agar plate and incubated overnight to detect any mixed growth. Whereas media control is the basal media without antifungal and without test organism. So endpoint interpretation control is very, very important in your media control. Periodically, it is done to minimize variation in the interpretation of MIC endpoints among observers. So different observers, because this is purely visual interpretation. So it varies between the experienced and inexperienced. So henceforth, inter-observer variability you have to check when you are doing the MIC interpretation. QC strain. Ideal reference strain for QC of dilution tests have MICs that fall near the middle concentration range tested for all antifungals. So it should be within the middle concentration range. It should not fall on either side. So it will be very difficult to interpret in those cases. So there is epidemiological cutoff value. What's the time? 6:46. So I will continue with this, and then Dr. Shiv Prakash will continue. So I will continue a little bit with epidemiological cutoff, and I'll join back with you after his talk. So epidemiological cutoff value. So there are two terms, ECV, which is CLSI term, and ECOF is UCAS term. So when we say epidemiological cutoff value, so it is something that is being observed in the wild type strains. And you usually tend to interpret it in the form of MIC or MEC. When we are talking in the yeast, preferably we report it in the form of minimum inhibitory concentration. And when we are trying to report in molds, there is also one important terminology, that is minimum effective concentration, MEC. So wherever there is actually paucity of data, because why this MIC is not converting itself into a breakpoint. What is a breakpoint? Susceptible, intermediate, resistant. These are the breakpoints. So we do not know for many of the organism and drug combinations that what is the interpretative breakpoint. So it becomes very difficult to report to the clinician whether this is susceptible, this MIC, or resistant or intermediate, or susceptible dose dependent, which is very common in the fungal interpretation. So in those cases, epidemiological cutoff value can also be used for reporting. And epidemiological cutoff value is that separates a population of isolates into those with or without acquired or mutational resistance by defining the upper limit of the wild type MIC or MEC distribution. It is not a breakpoint and should not be used as such or considered equivalent to a breakpoint. So unlike a breakpoint, an epidemiological cutoff value does not necessarily predict clinical success or failure of a particular antifungal, but rather predicts whether a specific isolate carries resistance to a drug which is known to otherwise have activity against the species. So this is what is the only report that you can give. And it has no utility for species where there is intrinsic resistance, like Cruzia and fluconazole. This is known, so there is no point in giving any such report. So for many fungus antifungal combinations with no breakpoints or without any epidemiological cutoff values also, the only thing that can be reported is MIC value. So there are debates that you have only MIC value here, you do not have any breakpoints nor epidemiological cutoff value. So how reasonable it is to report this MIC? Should we report or not? There is no choice, no breakpoints, no epidemiological cutoffs, so you can give an MIC, but with lot of limitations. Now there is a second condition where there are breakpoints available, like susceptible, intermediate, and resistant. So in those cases, how far we can go ahead by giving the MIC reporting? Is there a need to report the MIC to the clinicians? So yes, there have been examples where people have said that in cases of susceptible dose dependent and resistant are the only breakpoints available. So those organism and drug combinations where there is no susceptible category, like Candida glabrata and fluconazole, we need to give the MIC to the clinician. So those cases it is justified to give the MIC because you don't have, because they are overlapping. So a clinician need to choose the range. What is the actual MIC? What is at what dosing I have to give for this patient? What is the treatable dose that I can give to this patient? He need not go up to very high levels. So in those cases, MIC is very important. Then challenges in interpreting broth microdilation include some of the phenomena which are actually complicating the endpoint determination, like phenomena of trailing growth. So usually it is observed in case of fungistatic azoles in case of yeast, whereas the trailing growth is also seen in the molds, and this is seen with the echinocandins on the mold species, because echinocandins are fungicidal in case of yeast, whereas they are static in case of the molds. So in this case, actually, because of the stress response, the trailing growth occurs, and it appears at high drug concentrations, and they remain susceptible. Actually, this is susceptible, but in this case, we actually falsely report it as resistant. So when we visualize in a microbroth dilution assay, this phenomena appears as a reduced yet persistent microbial growth beyond the MIC cut point. So trailing growth may present difficulties when you're trying to interpret the results. And what CLSI defines is that usually it is misinterpreted as drug resistant. And most common in the Candida species in which trailing growth is observed are the Candida albicans and Candida tropicalis. Now, trailing growth in case of echinocandins and more species is because growth is not inhibited, but rather changed. So interpretation becomes subjective and may cause a determination of false resistance, because I told echinocandins, they are not fungicidal in case of mold species. So this is how the yeast trailing growth you can see. So even after the MIC, there is a further growth that can be visualized. So that is what is the trailing growth. And in case of MECs, because minimum effective concentrations are what is seen in case of molds with the echinocandins. So here also, once there is a clearing, after clearing again, you can see the growth. So that is what is the observed as the trailing growth. Now, third challenge is the paradoxical effect, which can obstruct appropriate reading of broth microdilution, especially for Caspo and some Candida species. Now, paradoxical effect is seen instead of the consistent growth across the wells, as seen in trailing growth, there is a distinct drop-off in growth. So here we can see this asterisk sign is there. So there will be sudden drop-off in the growth, and then a distinct regrowth which appears. Sudden drop and sudden regrowth. Sudden drop. So that is actually what is observed as the paradoxical effect. This is also known as the eagle effect. So the mechanism underlying this is again a stress phenomenon, where there is a decrease in cell wall component of the 1,3-beta-glucan. That is, the fungus has learned that it is targeting, the antifungals are targeting 1,3-beta-glucan. So I should make more of chitin. So there is increase in cell wall chitin content, which frequently indicates sources of regrowth. So there is no clear connection between in vitro paradoxical growth of an isolate and in vivo resistance. So in this case also, we are actually overdoing with the resistance. So current guidelines, you have to look for the epidemiological cutoff values. So this is how you have to compare, and you have to get the recent ones so that you can give good reporting. So for few only, you can see that there is the CLSI epidemiological cutoff, but UCAST, you are having lot of antifungal and species, you are getting epidemiological cutoff value. Also, current antifungal breakpoints are interpretative categories for yeasts and molds. So these are the current guidelines in 2019. So we can see the CLSI breakpoints. They have got the susceptible, intermediate, susceptible, dose resistant, and resistant. So this is the UCAST breakpoint. So the number of species that are being reported for some antifungal and the species combination, we don't have the CLSI breakpoints, but we do have some breakpoints in UCAST. So there are some alerts with CLSI M27 document. Caspofungin susceptibility testing in vitro is associated with significant interlaboratory variability. So this is actually very important. If there is susceptibility with caspofungin, report it. But if it is intermediate or resistant, you require additional testing with Mica or Anidula fungin. If possible, go for sequence analysis and send to referral center for confirmation. So I think now I think the screen is shared. So we are comparing between the M38A2 and UCAST, that is the document 9.3.1. So here the major difference in the yeast and the molds is, in case of molds, there is slight difference between non-dermatophyte and the dermatophyte filamentous fungi, whereas UCAST has no recommendation for the how to measure the inoculum in case of the dermatophyte molds. There are several studies which have compared with the broth microdilution and other techniques. Reading is again visual in CLSI, and UCAST is spectrophotometric. Incubation time is usually at 48 hours of incubation for UCAST. And amphotericin B reading, if we look at it in case of CLSI M38, it is 100% decrease in growth and 90% decrease in growth for the UCAST. So the most important parameter in CLSI for incubation time, it is very important that it gives you species-wise difference. Rhizopus species, 21 to 26 hours incubation is important. Aspergillus fusarium sporothrix, 46 to 50 hours. Schistosporium species, somewhere around 70 to 74 hours. And dimorphic fungi, incubation period is 5 to 7 days. So in case of opportunistic fungi, if you want to interpret, you have to regularly look for the drug-free medium or the growth control, where you are seeing, if you are seeing that there is confluent growth, then you can report your interpretation. So MIC definition for amphotericin B has been given: itra, vori, and posaconazole and rabuconazole. So MIC, what is defined by CLSI, is lowest drug concentration that prevents any discernible growth. So 100%. So it is just like your broth microdilution for yeast. But in case of UCAST, again, it is similarly what it mentions. So there is no difference in this aspect for MIC. When you come to MEC, MEC is something which is specific for the molds. You don't find MEC in case of the yeast. So it is the lowest concentration where you're finding that there is a formation of rounding, compact, and small colonies after 24 to 48 hours of incubation. So this is the minimum effective concentration, because you don't have minimum inhibitory concentration for echinocandins. And you have to use specific QC strains like Paecilomyces variety and Candida krusei ATCC and Parapsilosis. These Candida species cannot be used for echinocandins, because if you're using them, then you don't find this compact formation, because it will give you MIC only, because for yeast it is MIC. Now coming to M44. So this CLSI guideline is for the disc diffusion for the yeast. So method for testing of Candida species and zone breakpoints for fluconazole and voriconazole have been provided with the QC parameters. And we also have nowadays for POSA and caspofungin. Qualitative results are seen in 24 hours and it is readily available. There is not much cost involved as compared to BMD. BMD, there are a lot of limitations, like to perform it regularly, there has to be a dedicated person who is doing it. Then he should or she has to be technically trained, and the observer has also to be trained. The person who is interpreting the results or reports has to be trained. And you need some equipments like for filtration of the media. You have to filter the medium that you're preparing so that there is no contamination. You have to syringe filter your antifungal drugs so that again they are not contaminated. You need -20 if you are deep freezer, if you want to preserve the plates for longer duration. So these are some of the costs that go in, and you require a lot of powders, antifungal powders, which are also to an extent slightly costlier compared to antibiotics. So this is something that actually disc diffusion, which is encouraged because of these factors. And the development of testing and other antifungal agents also for various genera, it can be tested. So equipments are very nominal in case of yeast disc diffusion. Incubator set, McFarland 0.5 turbidity standard, cotton swabs, not synthetic polyester fibers, but cotton swabs, and sterile physiological saline, Muller-Hinton agar, and antifungal discs. Antifungal discs from High Media or from Sigma, from any company which has shown good results with your controls, they can be chosen. And the storage temperature of the antifungal discs is important. You can store them somewhere between around 8 to -20 also. And Muller-Hinton agar, GMB is the medium, which is 2% glucose, 0.5 microgram per ml of methylene blue dye. It is readily available, and good batch-to-batch reproducibility has been obtained. It can be supplemented with glucose, which is suitable for fungal growth. So in case of CLSI, you can add somewhere around 0.2% or 2%. So this supplementation of glucose around 2% encourages good growth. So methylene blue dye, it enhances to visualize the zone edge, and medium is supplemented either pre or post production with methylene blue. So pH of the medium is 7.2 to 7.4. In case of your broth microdilution, the pH of the medium should not exceed beyond 7. It should be limited between 6.9 to 7. It has to be 7. Whereas in case of pH of Muller-Hinton agar, for disc diffusion, it can have a range of 7.2 to 7.4. And moisture on agar surface, if it is excess, you should dry the plates before putting the discs. Storage of antimicrobial disc, as I told you, you may keep it in the normal refrigerator at less than 8 degrees, around 4 degrees centigrade. And turbidity standard for inoculum preparation is, you require turbidity standard, which you can very well prepare in-house for 0.5 McFarland standard, which is available with everyone. Standard strains: Candida albicans, ATCC, Candida parapsilosis, Candida tropicalis, Candida cruziae. So these are the standard strains which you require. You have to subculture to ensure purity and viability, and you have to incubate them at 35 degrees centigrade. Inoculum preparation is by picking up 5 colonies, 1 mm, suspended in 5 ml of sterile saline, 0.145 moles per liter, and you have to vortex them well for 15 seconds and you have to adjust the turbidity. Either you can use a spectrophotometer if you have, or with 0.5 McFarland standard you can adjust. Each stock suspension contains roughly around 1 × 10⁶ to 5 × 10⁶ yeast cells per ml, which produce a semi-confluent growth with moist Candida species. Within 15 minutes, you have to dip the sterile cotton swab, and just as you are doing for the bacterial isolates, you have to squeeze or remove the excess of the inoculum, and you have to streak twice by rotating the plate around 60 degrees centigrade, and finally you have to swab the rim. You have to cover the plate with the lid for 3 to 5 minutes, and then it should not exceed in any way more than 15 minutes, and immediately apply the drug impregnated discs. So these discs can be prepared in-house, but preferably people buy from outside. And antimicrobial discs, they have to be placed 24 mm apart, center to center. 12 discs in 150 mm plate is enough, or 5 discs on 100 mm plate. And once you have plated the disc, do not displace them, because as soon as you have placed the disc, the drug has already diffused within seconds. And you incubate them at 35 degrees centigrade within 15 minutes. So read around 20 to 24 hours of incubation. So zones uniformly circular semi-confluent. So that is very important. You have to look for the uniformity. And zone diameter to the nearest mm. Pinpoint microcolonies at zone edge can be ignored. So these are pinpoint colonies which can be ignored at the zone diameter. So read at 48 hours, and if you feel the growth is insufficient, you can always further incubate. It is highly subjective, and their experience is required for greater efficacy. So there are interpretative breakpoints for the yeast disc diffusion: susceptible, dose dependent, and resistant. Susceptible, the recommendation is that this drug can be at this dose, it can be treated at the recommended dose. And susceptible dose dependent means MICs that approach attainable blood and tissue levels. So here you can increase the dose. dosage so that it is neither is reaching the toxicity level nor it is ineffective. Resistant, it is not inhibited by usual achievable concentrations. So interpreting fungal MICs is very tricky. An MIC, which is we call it as an artificially derived in vitro measure of drug activity, and the real value can only be attained for MIC once you are having some clinical outcome or treatment. So both these combination are called as the established breakpoint. So clinical breakpoint for fungi have been available since around 2012 or 13. Broad range of Canada-based interpretive criteria were applied. E-tests and distributions, they do not have clear clinical breakpoints, and many species have got no interpretative criteria. Currently, there has been development of lot of stress has been given on the epidemiological cutoff values, and there are 4 important parameters to achieve a clinical breakpoint. First, you need to have MIC of the wild type distributions per species. Then you have to look for the dosing regimens, and you have to look for the adverse effects, adverse drug toxicity or adverse drug effects based on achievable drug serum levels. Then you have to have the MIC and efficacy and outcome of clinical trials. So you have to have a lot of clinical trials with antifungals and PK/PD analysis. So based on above 4 criteria, you can derive some breakpoints as susceptible, intermediate, resistance. So this actually breakpoints then helps you to differentiate between what is treatable and what is not treatable. So MIC, lowest concentration that inhibits the growth. So this is the MIC. MIC is the lowest concentration which actually inhibits the growth. Epidemiological cutoff value, if you look at it, for several wild type strains, so if there are 100 wild type strains that have been studied, so the highest MIC in the entire distribution of the wild types by phenotypic testing, so this highest MIC is actually an epidemiological cutoff value. Then you have clinical breakpoints. So this is the highest MIC with maximum clinical efficacy. It is based on after considering the clinical trial and the outcome results. And the pharmacodynamic breakpoint is highest MIC where total availability and toxic effects are less. So how do you select a clinical breakpoint from the wild types? So susceptible breakpoint is considered as the highest MIC at which the drug is susceptible, and resistant breakpoint is lowest resistant lowest MIC at which the drug is resistant. So this is the resistant breakpoint, and susceptible is always the highest susceptible. So we have susceptible breakpoint. So this is the whole susceptible breakpoint, but we are choosing the highest susceptible breakpoint at which the drug is susceptible to call it as a susceptible breakpoint. Whereas for resistant, we always consider the first one, that is the lowest MIC at which the drug is resistant. So CLSA M60 is a document which you can always refer to for the breakpoints, minimum inhibitory concentration breakpoints for in vitro broad dilution susceptibility technique. So this you are getting for various drugs and species combinations. Similarly, you have got a detailed thing that is given in your M60 document. Now, this is a summary of antifungal susceptibility testing. So for some drugs, we know this is a chart of intrinsic resistance. So this is purely for intrinsic resistance. For Candida albicans, there is no intrinsic resistance. Glabrata, we can find less active. Azoles are very less active against Glabrata. For Cruziae, there is fluconazole resistance. And if you look at Tropicalis, all the antifungals have very good action. Parapsilosis, there is not much role of echinocandins. For Candida lucitianae, amphotericin B it is intrinsically resistant. Cryptococcus neoformans, amphotericin B, flucytosine combinations are given. Azoles to an extent have very effective, but echinocandins have no action, which we have already read in the working group decision of reporting. Trichosporon, geotrichum. So trichosporon, again, no action of echinocandins and amphotericin B. Geotrichum candidum, it has the limited effect of the caspofungins as well as the fluconazole, itraconazole. Rhodotorula, only amphotericin B. Sporovolomyces, amphotericin B, and some of the azoles are also active. Similarly, if you look at the antifungal intrinsic resistance pattern in case of the molds, so there are some endemic molds. So among the endemic molds, you have got good action of most of the antifungals. When it comes to sporothrix, fluconazole and echinocandins have no action. Voriconazole has limited effect. Aspergillus fumigatus and Aspergillus flavus, there is some problem with the intrinsic resistance with fluconazole. And Aspergillus tereus, there is intrinsic resistance with amphotericin B and fluconazole. Fusarium solani, intrinsic resistance with amphotericin B, fluconazole, itraconazole. Rhizopus species, mucor, these are actually having the amphotericin B is effective, but it has got a less activity compared with posaconazole. So now there are a lot of recommendations to give posaconazole in case of mucormycosis if there is some toxicity or if there is some impact with the amphotericin B. Similarly, Schistosporium epiospermum, Lomentospora prolificans, you can see there is not much choice for Lomentospora. Even for demeticious fungi, there is not much choice of antifungals because most of it either it is intrinsically resistant or there is no action or limited action. So if you look at the summary of methods of AFST that are available, broth microdilution is considered as gold standard both for the yeast as well as filamentous fungi. And the weakness is that it is very subjective in case of CLSA methodology, whereas UCAST recommends for use of spectrophotometer, labor intensive, expensive, and technical training is required. This diffusion is standardized, inexpensive. This can be produced in laboratory in-house if we feel that it is costly to purchase. But there are very few interpretative guidelines or breakpoints available. So it is very difficult to interpret. And disk diameters are categorical only and do not directly correlate with the MIC values. So in later part, we will discuss what is categorical agreement and what is the essential agreement. Gradient diffusion technique, that is yeast strips, it is inexpensive compared to broth microdilution and can be used for both yeast and filamentous fungi. They're good for resource limited settings and they provide the MIC value. Now, what is important is must be purchased commercially, cannot be prepared in-house and not available for antifungals in development. There are some other techniques like the yeast 1, Vitek 2, agar screening for Aspergillus. They are easy to perform, but agar screening is only for screening test. Vitek 2, there is no subjectivity to interpretation, but it is expensive for both initial startup costs and for cartridges, and it cannot be used for filamentous fungi and available for only a limited number of antifungals and overcaused resistance for some species like Candida auris. Yeast 1 interpretation is again less subjective than standard broth microdilution, easier to train new technicians and long shelf life of dried trays. You do not require free storage. So this is one of the advantage. But interpretation of trailing growth in azoles can be problematic. So this trailing growth of azoles, what we have observed, can be problematic and cannot be used for filamentous fungi. All this has to be purchased commercially. So MIC detection methods, we have broad dilution, tube, and macro and micro broad dilution. Agar dilution, that is MIC by agar dilution. Gradient diffusion again gives you MIC yeast strip. Now we have got yeast 1, what we were discussing, sensititry. Many centers are using, now there is a sensititry, non-automated, semi-automated and automated versions which you can give, and they customize based upon the isolates you are using, a number of isolates that will be, or throughput they are seeing. Based on that, the company can customize. So sensititry many centers are using, where already prepared plates are given to you, so that you don't have your technicians preparing the broth microdilution inoculum, that plates are not prepared. You only have to prepare the inoculum and put it. So usually these are based on calorimetric assay, and there is iMARC blue indicator, and 0.5 McFarland initial inoculum is required. It has got a media of RPMI with 0.2% glucose. Round bottom wells are there, 24 to 48 hours incubation, and up to 9 antifungals can be tested. But if you have one plate can be dedicated to one antifungal with multiple isolates, so they customize based upon your workload. So automation techniques are there. We have several BD and Vitek, several automated methods which are available. Also automated performance of sensititry is also available. So other AFST methods in comparison to reference methods. So how are we going to compare our AFST methods with other reference methods? Like we told that we are performing broth microdilution, we are performing the disk diffusion. Suppose I want to compare sensititry with my broth microdilution method. If I want to compare the yeast strip with my broth dilution method, agar screening method with broth dilution method. So what are the ways how you have to compare? So there are some terminologies as verification and validation. So if you look at validation, it is an ongoing process of evaluating the test performance over time and is part of laboratory's quality assurance program. So you have quality control testing, internal or external proficiency testing, and personal competency assessments. Whereas if you look at verification, it is a one-time process of determining that a test performs correctly. So a verification study is actually conducted to determine the performance characteristics of an assay prior to use of the assay for patient care. So whenever you are trying to use any other method, you have to have a verification done, and it has to be done with a gold standard. Suppose disk diffusion and automated AST. So that again, in that you are trying to look at the relevance, performance characteristics, precision, then essential agreement, categorical agreement. Essential agreement is MIC test to MIC test is essential agreement. So how do you verify these comparison studies? MIC method is a reference method, and the new test is also MIC method. So one MIC method is tested to another MIC method. If MIC method is tested with disk diffusion method, then this is known as the categorical agreement. So if we look at MIC versus MIC categorical agreement, your minor errors are susceptible versus intermediate, intermediate versus resistant. So when you call essential agreement, the essential agreement is between the MICs, and categorical agreement is between the interpretative guidelines, like susceptible in MIC is susceptible in disk diffusion, resistant in MIC is resistant in disk diffusion, intermediate in MIC is intermediate in disk diffusion, or susceptible to disk diffusion. So those are categorical agreement. When you say essential agreement, the MIC you got by one technique is the same, or there is a 2 MIC difference between the second technique. So that is what 2 dilutions, up to 2 dilutions difference is taken as the comparison that comes under the essential agreement, up to 2 dilutions difference. So this essential agreement is same MIC value with only 2 dilution difference you are considering as the essential agreement. So there are some terms when you're trying to verify one technique with the other, like minor error, major error, very major error, and reproducibility for essential agreement with categorical agreement. So minor error is if a susceptible versus intermediate, intermediate versus resistant. Suppose you got intermediate versus resistant. So this has got least detrimental effect on a therapeutic decision. So you have got MIC versus MIC. Major error is resistant result is obtained by new method, and a susceptible result is obtained by the gold standard method. So that is very tricky. So in case of minor error, susceptible result is obtained by the new method, whereas resistant or intermediate is obtained by the old method or the standard reference method. There is intermediate or resistant. So in those cases, it is minor error. So these are some terminologies we have to be familiar with. Then very major error is susceptible result by new method, and a resistant result by the gold standard method. So this is considered as the most serious error, and we should not continue that assay, or we should try to rethink of how to perform it. So these are the parameters based on which you are concluding which test is better. So commercial testing methods like gradient E-strips have been available. So they have been tested for these essential agreement, categorical agreement for Candida species, Aspergillus fumigatus, and Aspergillus species. So what they have observed is that there is, if you look at this, 83 to 100%, this is actually percentage, this got wrongly typed. So this is percentage. So the Aspergillus species, if you look at it, the essential agreement is 83 to 100%. Whereas for itraconazole and voriconazole for Aspergillus species, essential agreement is 96 and 98%. Whereas for fumigator specific, it is, the range is quite wide for essential agreement. So these are the parameters. So what overall interpretation by studies that have observed is that gradient diffusion versus broth microdilation for Candida and Cryptococcus species for amphotericin B, they have seen that compared to broth microdilation, the gradient diffusion technique is better for Candida and the Cryptococcus in case of amphotericin B. Gradient diffusion is of advantage in cases of trailing growth interpretation susceptible from true microbiological resistance compared to BMD. Because trailing growth is something that is a problem to interpret in broth microdilation. So in those cases, the recommendations say that you use E-strip method or gradient diffusion technique to get an MIC for Candida and Cryptococcus. Comparing between E-strip and the disk diffusion test, triazoles and amphotericin B for molds, except mucormycetes and dermatophytes. So these are comparable. Commercial testing methods with sensititary 1 assay and the broth microdilution. So interpretative categorical agreement for this assay is lowest for Candida glabrata and tropicalis. So this assay is not recommended for molds as still there are trials, and reproducibility overall for essential agreement is 99%. Vitek 2 test panels with bioMario. Manual readings not possible, and in USA only fluconazole, worry and caspofungin have been approved by FDA for antifungal assessment with Vitek 2. So these are some of the limitations with Vitek 2 also. Flow cytometry, MALDI-TOF, these are still tried as the techniques. So high overall essential and categorical agreement with CLSA BMD, but there have been very major errors reported with Candida cruzi. Similarly, MALDI-TOF mass spectrometry for Candida species and Aspergillus species. A complete essential agreement has been seen with caspofungin, but categorical agreement is somewhere around 94.1%. So this actually reproducibility is also a problem with MALDI-TOF. Agar-based antifungal screenings are also available. There are different plates like X-plate method, then Aspergillus screen plates. So there are different. So if you look at the literature, you need to compare with your new test with the reference standard based on these parameters as essential agreement, categorical agreement, minor error, major error, and very major error. I'll take some more time discussing about the antifungal drugs and mechanism of drug resistance in the fungi. So by this time, we have known the targets of licensed antifungal drugs. So azoles, they inhibit the fluconazole, voriconazole, itraconazole, posaconazole. So all these azoles, they inhibit ergosterol biosynthesis. Polyenes like amphotericin B, they bind to ergosterol in plasma membrane and form large pores. So there is disruption of the cell function. 5-flucytosine, it inhibits pyrimidine metabolism DNA synthesis, and echinocandins, cell wall active agents, they inhibit the beta-1,3-D glucan. So there are different mechanisms of action, and squalene is converted to lanosterol and ergosterol. So squalene epoxidase enzyme, this function is done in case of the naftifine, and the lanosterol synthesis is inhibited in case of terbinafine, amrolfine, naftifine, which are used for the dermatophytes. So currently available under trial antifungal agents are also described here. So under trial in case of polyenes are liposomal nystatin, amphotericin B cochleates. For among the triazole, if you have under trial is albaconazole, and echinocandins, aminocandins, risafungin is something which is under clinical trial. Among the azoles, there are several azoles which are used. So the role of azoles is very different. Few azoles are used topically, some are used topical and systemic, and few azoles are systemic. So nystatin is too toxic for systemic use, and it is limited only for topical treatment. Now echinocandins are fungicidal for yeast and static for molds, but all are given by IV route. So there are a lot of limitations when you're giving antifungals. Either the mode of administration is difficult, testing in some is difficult, and toxicity is high in many of the antifungal drugs. Terbinafine and tolnafate, they inhibit the squalene epoxidase, resulting in accumulation of squalene inside the fungal cells. It is given orally, and the target tissues are those that are not well vascularized, because I told it is preferably given in case of skin, hair, and nails of dermatophytes. Yet this drug is given orally and not applied topically, whereas bisulfulvin is an older orally active drug used for dermatophyte infections. So there are several cellular and biochemical targets of investigational agents. They are still not been given their names. Some of the antifungals have only numbers. So these are several newer pathways or newer biochemical targets, and these are some drugs which are in pipeline. Out of these, the VL2397 and ASP2397, these are natural products from acrimonium, and they have got unknown intracellular target. MK3118 SC/078, first in the class of triterpenoid. This is a novel class of beta-glucan synthase inhibition, and it acts at different site than echinocandins. So it comes under the glucan synthase inhibition only, like the echinocandins work, but these are considered as the site is different, so they are considered slightly newer than the echinocandins. F901318, first compound in orotomide class, and dihydroorotate dehydrogenase inhibitor is what it inhibits. So what are the mechanisms of resistance to antifungal drugs that target the cell membrane? Cell membrane is targeted by azoles and polyenes. Azole resistance can emerge through multiple mechanisms, predominantly overexpression or alteration of the drug target, upregulation of drug transporters, or cellular changes that reduce the drug toxicity or enable tolerance of drug-induced stress. Pollen resistance commonly involves depletion of target ergosterol attributed to loss of function of mutations. So these are mutational based. So genetic mechanisms, if you look at in Candida and Aspergillus. So for azoles, target cell alteration, mutation of ERK11. So decreased affinity of the ERK11, intrinsic resistance to fluconazole in Candida krusei isolates, and decreased drug concentration, that is efflux prompts in place. So this is more important in case of some of the Candida species. So bypass pathway is another pathway, and chromosomal aneuploidy or isochromosome. So these are some of the pathways. Whereas in Aspergillus, what we see is CYP51A, that is mutation at codon 220, it develops resistance to all azoles, and mutation at codon 54, it develops cross resistance to ITRA and the. So there is increased CYP51A. So these are the different mechanisms. So if you look at it, in case of azoles, in case of yeast, if you look target site alteration or overexpression, upregulation of multi-drug transporters for azoles like fluconazole. In case of Candida albicans, if you look at Cryptococcus, there is mutation in ERK11, overexpression of AFR1 because of chromosome 1 duplication, and mediators of stress response. In case of Aspergillus fumigatus, there is CYP51A and HSP90, which is the key mediator of the stress response pathways. So genetic mechanisms of resistance in Candida and the Aspergillus, they are very important areas of work and which has to be studied. So these are different literatures are available to evaluate these and to look for what is overexpressed and what is upregulation mechanisms, stress mechanisms. So in fungus, as many mutations have been described. Similarly, the stress responses have also been given significance. So mechanisms of resistance to antifungal drugs in case of echinocandins, mutation in FKS1. So this is very, very important, as we have already discussed that in caspofungin, if it is susceptible, we are reporting susceptible, but intermediate or resistant, we have to look for this mutation of FKS1. And cellular stress response is another pathway. There are no uptake the efflux mechanisms that you find with echinocandins. So target site cell alteration is very characteristic in case of Candida, and FKS1 is involved. So echinocandins, there is mutations that have played a lot of role. There is no upregulation of multi-drug transporters. There are two mechanisms, that is target site alteration and cellular stress responses, which are important. So there have been a lot of studies on the mutations between different species of the FKS genes. So these are very important if you want to know the resistance. Now, drug resistance in the dermatophytes, particularly Trichophyton rubrum, terbinafine, the mechanism of action is inhibition of squalene epoxidase. So the mechanism of resistance is modification of the target enzyme by mutation, increased drug efflux, stress adaptation, or overexpression of salicylate monooxygenase. In case of fluconazole against dermatophytes, there is inhibition of cytochrome P450. This is how the mechanism of action occurs. But here, in case of resistance, there is increased reflex and stress adaptation. There is not much mutation. So there are a lot of such azoles which are used for dermatophytes, and predominantly the mechanism of resistance is stress adaptation or the efflux. Only with terbinafine, there is modification of the target enzyme, that is squalene epoxidase. So this has to be remembered. Terbinafine, there is modification of target enzyme, and this is the only one which is associated with mutation. Similarly, there are other drugs where predominantly what you find is increased drug efflux and stress adaptation. Another very important problem with the Candida species is, even if you have tested with antifungal susceptibility testing and you have said that this is susceptible, but in vivo it may not act because of biofilms. So we know what is a biofilm. It is a dense network of yeast and filamentous cells embedded in exopolymeric matrix consisting of carbohydrates, proteins, and nucleic acids. So this is a major feature that distinguishes biofilms from planktonic cells. And Candida biofilms have been considered to be intrinsically resistant to azoles. And there are multifactorial mechanisms like drug efflux transporters and drug sequestration within the extensive matrix structures. So the matrix production is highly regulated, and key resistance factor for Candida species is Candida albicans, glabrata, paropsilosis, topicalis, and dupliensis. And the key biofilm constituent is beta-1,3-glucan, which is produced by glucan synthase. The downstream components of yeast like PKC pathway, other FKS1 cellular components, they act as transcription factors and affect the matrix production. And hence these isolates become the resistant phenotypes. So these were the references, and all the CLSI guidelines, they have to be referred, and they have to be understood to know the antifungal susceptibility testing. So the take home message here or summary here is we have to know all the documents. For yeast, the broad dilution document is M27. For molds, it is the M38, whereas M44 is the disk diffusion method for yeast. M51 is the disk diffusion method for the molds. There is only change. What you find is the inoculum change and how you prepare the inoculum. Now there are recommendations with 0.5 McFarland standard, which can be used for dermatophytes also. There are several studies which have documented, which you can refer to. M60, M59, these are reference methods, reference documents for the epidemiological cutoff value and interpretative guidelines. So thank you. Now we will play a short video which will summarize quickly. Many centers would have already doing a lot of AFST. So we just have a summary of this. And for beginners, you can just take just an overview and then you can start.
Good evening to all. I am Dr. Anish, resident from Microbiology department. Today we discuss the broth microdilution technique for yeast as per the CLSI guidelines. There are three very critical steps. The first step of which is the preparation of the antifungal reagent. Today we demonstrate the preparation of the antifungal stock solution for fluconazole, which is generically derived from sigma. What you see in the video is the weighing of the drug. Here we find that 6.53 milligram per ml of DMSO, that is a solvent used for dissolving the insoluble fluconazole, is measured in the weighing machine. And then we observed that the same drug is dissolved in the corresponding amount of DMSO, which is calculated as per the formula. So the two formulas that we use here are already described. The first of which is weight in milligram equal to volume into concentration upon potency. The potency which is given to be 980 microgram per milligram as given by the company, and the volume is measured as per the formula potency into weight in milligram upon concentration. The drug after preparation is properly sealed with paraffin and stored in -20 degrees Celsius until usage. Next, we look at the media preparation for the same. Here we use the medium RPMI 1640 with glutathione, without bicarbonate, without phenol red. And we see that for preparing 500 ml of the RPMI media, we take the corresponding amount, that is 5.2 grams of the RPMI, measure it, and then it is dissolved in 300 ml of distilled water. After dissolving, the next thing that needs to be added is a MOPS buffer. The MOPS buffer that is required for 500 ml is 17.25 grams. We measure the same and then add it to the buffer. So 17.25 grams is what we need. So that is what we have added. After the same, we should remember that in the CLSI method, we need to add 0.2% of sugar. That is also correspondingly added to the media. And the next critical step in media preparation is checking the pH. pH checking is done using pH indicator solution that is commercially available. The pH is 6.8 to 7 that is required. And the final step in media preparation is filtration. For filtration we use vacuum pumps, and that is what you see in the image. After filtration, is we seal the same and store it in 4 degrees Celsius. Next is the inoculum preparation. Here we see that we have to measure the inoculum using a spectrophotometer for the turbidity, and this measurement is done at 530 nanometers. So the spectrophotometer is set to 530 nanometers. Now the subculture of the isolates, that is, in one plate we can check for 7 isolates and 1 control, that is Candida parapsilosis. These isolates needs to be subcultured in plain SDA, and the age should be 24 to 72 hours. From the subculture, the inoculum is prepared in distilled water. 2 to 5 ml of distilled water is taken and the inoculum is prepared. When the inoculum is prepared, we need to ensure that when the turbidity is tested, the OD value should correspond to 0.45 to 0.55 at 530 nanometers by the spectrophotometer. So in the spectrophotometer, you must see that initially the reference that is used is distilled water. The value is set to 0 by using distilled water before testing our corresponding isolate. Once the inoculum is ready, we will move on to the next step, that is plating. So here may notice that what we can observe is we need an 8-channel pipette and a 12-channel pipette, and here we will say there are 2 rows of test tubes set. The first row contains 10 test tubes, second row contains 10 test tubes. The first row T1 to T10 labeled and second row labeled T1 dash to T10 dash. So here we notice that the first test tube in the first row is a stock solution which is brought to room temperature, 0.5 ml of which is taken to the next 3 test tubes, T2, T3 and T4. Then we understand that we add DMSO to the first row of test tubes in the following volumes: 0.5 ml to T2, 1.5 ml to T3 and 3.5 ml to T4. And after mixing the T4 well, we add 0.5 ml from T4 to T5, T6 and T7 respectively. Then again add DMSO to 0.5, 1.5 and 3.5 ml to T5, T6 and T7. And then after mixing T7, we add 0.5 ml from T7 to T8, T9 and T10 and DMSO 0.5, 1.5 and 3.5 ml respectively. This gives us the dilutions of the first row. The stock solution for fluconazole value was 6400. Now coming to the second row, what we see is that we need to prepare the concentration in 1:50 ratio. For this purpose, from the first row, we take 0.1 ml of the solutions correspondingly to the second row, that is from T1, which was a stock solution, we take 0.1 ml, and from T2 we take 0.1 ml to the T2 dash, and from T3 we take it to T3 dash and so on. Along with that, we may also note that we add RPMI to the second row in 4.9 ml volume. So this brings the ratio 1:50 and hence the dilutions in the second row is made. Next step is addition of inoculum and the drug in 1:1 ratio. So the inoculum, remember that the rows stand for the inoculum and the column stands for the corresponding drugs. And remember, the 11th column contains media and inoculum and the 12th row contains media only, and the 8th row will be positive control. After this, microtiter plate is closed and it is kept in 37 degrees Celsius for incubation. Today I present the antifungal disc diffusion susceptibility testing of yeast as per the M44 CLSI guidelines. The reagents that are needed for the disc diffusion test includes Muller-Hinton agar plus 2% glucose containing methylene blue dye, the pH of which is 7.2 to 7.4. The antimicrobial disc that are being tested, that includes fluconazole, voriconazole, amphotericin B and caspofungin E strip, can be refrigerated at 2 to 8 degrees Celsius or as per the recommendations of the manufacturer. The critical step in antifungal susceptibility testing by disc diffusion is the inoculum preparation. The inoculum preparation is done by direct colony suspension method, in which a subculture of age 24 to 48 hours on SDA media is taken, and by picking 5 distinct colonies of 1 mm in diameter is suspended in 5 ml of sterile saline. The resulting suspension is vortexed for 15 seconds and the turbidity is adjusted to match 0.5 McFarland at 530 nanometers wavelength. This procedure will yield a stock suspension of 1 into 10 raised to 6 to 5 into 10 raised to 6 cells per ml and should produce semi-confluent growth with most Candida species isolates. Once the isolation is ready, the plates are taken and ensured that there is no moisture on the surface of the plates. Optimally, within 15 minutes after adjusting the turbidity of inoculum suspension, a sterile cotton swab is dipped into the suspension and rotated several times and pressed firmly against the inside wall of the tube above the fluid level. This will remove the excess fluid from the swab. The dried surface of the Muller-Hinton plus GMB agar plate is inoculated by evenly streaking the swab over the entire surface. The procedure is repeated by streaking 2 more times, rotating the plate approximately 60 degrees each time to ensure an even distribution of inoculum. As a final step, the rim of the agar is swabbed. The lid may be left ajar for 3 to 5 minutes, but no more than 15 minutes to allow for any excess surface moisture to be absorbed before applying the drug impregnated disc. Now, application of disc to inoculated agar plates should be done with care. The discs must be evenly distributed so that they are no closer than 24 mm from center to center. Ordinarily, no more than 12 discs should be placed on a 150 mm plate or more than 5 discs on a 100 mm plate. And there must be no less than 10 mm distance from the edge of the petri dish. The plates should be inverted and placed in incubator at 35 degrees Celsius plus or minus 2 within 15 minutes after the disc are applied. The plates are read after 20 to 24 hours of incubation, and the interpretation of the disc diffusion results are done as per the interpretative criteria that includes susceptible, dose dependent, intermediate, resistant and non-susceptible according to the isolate and drug combination.
So this was the summary regarding how to perform the antifungal susceptibility testing. Regarding interpretation of plates, they have to observe visually. They have to observe visually for the growth that we are seeing and inhibition of the growth. In case of molds, it becomes minimum effective concentration. So everything to be shown videographically is slightly difficult. So interpretation part is something that has only been discussed with some of the photographs. So with this, we end today's session. We have covered today the molecular techniques of fungal identification, significance of MALDI-TOF, how it can be a better alternative to molecular technique, then therapeutic drug monitoring, and principles of AFST by disc diffusion, by broth microdilution for molds and for the yeast. And also, what are the mechanisms of drug resistance, and how we compare the reference or the gold standard with our new test. If we are choosing any new modality or new test of with new principle we are trying to test, categorical and essential agreement we have tried to understand. So all these are important aspects. And when you have to do AFST, we have understood only in selective cases we have to do antifungal susceptibility testing. Candida species from the blood sample is very, very important. So with this, we come to an end for today's session, and I request all the participants to refresh their windows, and so that you can participate in submitting the feedback forms for today's lectures. For the expert faculties, we do not have any feedback forms, but yes, there is a feedback for my session, because I need all the participants to analyze, and for any shortcomings, you can mail us or you can send us any kind of question that you want to send to any of our speakers.